And our objectives for our presentation today, we're both going to review national data relating to dental claims for silver diamine fluoride made to the Non-Insured Health Benefits program. And so I'll be speaking with one of the graduate student work that a student did with me related to children. Muhammad will present on the national data relating to dental claims for SDF submitted to the NIHB program for adults. And then lastly, we'll talk about some updates to SDF Clinical Guidelines, particularly the revised American Academy of Pediatric Dentistry chair-side guide. Next slide, please, Muhammad. And so I'll turn it over to Muhammad. I think it's exciting getting to present with a dental trainee. Muhammad's an outstanding speaker, so I'm going to let him give the refresher on SDF for you.
Thank you, Dr. Schroth, for outlining the background of this talk, and thank you, Daniela, as well, for the kind introduction. So I'm Muhammad, and I'm going to be starting off with a little refresher on silver diamine fluoride, which I'll be referring to as SDF. SDF is a non-surgical treatment option that's used to arrest dental caries that have progressed into dentin. Its rapid and simple application allows very easy use in people with limited access to care. And although it seems like a great treatment option, SDF causes an anesthetic black discoloration due to a protective layer of silver phosphate that forms to cover the carious dentin. SDF was approved by Health Canada in 2017, and the 38% formulation that is used in clinical practice contains 44,800 parts per million of fluoride and 253,870 parts per million of silver. And it's an antibacterial solution with 2,3 mineralization properties. Some of the advantages of SDF include that it's a minimally invasive treatment option, it's quite easy to apply, and the treatment time is much shorter compared to conventional restorative procedures. It's also fairly inexpensive compared to conventional restorations, and it's safe to use. Some of the disadvantages, however, include the black staining that I had previously alluded to, as well as the need for reapplications and regular follow-ups to ensure proper caries arrest. And even with these reapplications, there's always the risk of caries recurring. So here are a few images showing the before and after comparison of teeth to which SDF has been applied, and you can sort of note the black discoloration that has formed after SDF applications. Here are a few studies that are looking at the use of SDF. The first one here in Manitoba found a higher caries arrest rate in preschool-aged children with 2 SDF applications versus just 1. And the second study is a systematic review and a meta-analysis that found that 38% SDF is safe and effective at arresting dental caries in primary teeth with an arrest rate of 81%, which is quite impressive. And the third box here shows the guidelines from the AAPD, which support the use of 38% SDF in pediatric clinical practice. The Schroth lab also recently finished a randomized control trial that was comparing the effectiveness of 2 SDF applications with reapplication frequencies of 1 month, 4 months, and 6 months. And the findings were that the overall arrest rates after 2 applications were significantly higher when separated by 1 and 4 months periods. And this effect was seen to a lesser degree with 6 months in between the SDF reapplications. So now let's take a look at the Non-Insured Health Benefits Program, or NIHB. It's a Canadian government insurance program that's available to registered First Nations and Inuit people who don't have any other form of medical coverage. The eligibility criteria includes being a resident of Canada and being either covered under the Indian Act, an Inuk recognized under the Inuit Land Claim Organization, or a child under the age of 2 whose parents are NIHB eligible clients. And I would like to acknowledge that the data that we used for the study was provided to us from the NIHB. In August of 2020, the NIHB included a procedure code to cover SDF, making it the first government insurance program to do so. And during our data collection period, the NIHB limited SDF applications to 3 treatments per 12-month period for children under the age of 16 and 1 treatment per 12-month period for adults aged 17 and older. However, this has now since been increased to 2 SDF applications per year for adults. So I'm going to pass it on to Dr. Schroth, who is going to talk about the use of silver diamine fluoride in pediatric populations.
Thanks very much, Mohammed. So I will present work completed by Dr. Mohammed Al-Azraq, who is a practicing pediatric dentist in Nova Scotia, who did his residency training here at the University of Manitoba and did his research in the lab. And as Mohammed has mentioned, we are using data provided by NIHB. Mohammed, next slide, please. So the work here that, in case you're interested, Mohammed's project has already been published in Health Promotion and Chronic Disease Prevention in Canada. This is a journal published by the Public Health Agency of Canada, and it was quite nice to have a dental topic in this journal. This was a large data sample, and so next slide, please, Mohammed. So the objectives were really to look at the number of claims submitted by to the NIHB by dentists and dental providers in Canada for SDF for children, to look at trends in the number of claims over time, to determine whether there are regional or provincial differences in claims for SDF, and lastly, to determine whether SDF treatment is also provided in conjunction with traditional restorative treatment on the same day of service. So next slide, please, Mohammed. So ethics approval was obtained from the University of Manitoba, at the time our Health Research Ethics Board. The NIHB program provided us through their Home Department, Indigenous Services Canada. They provided us with the data through a secure data portal transfer. The data were then stored here at the Children's Hospital Research Institute of Manitoba, and all data on patients and providers were de-identified, so personal information was scrubbed before the data arrived to us. So we had no way of identifying participants or the claimants who were submitting claims to NIHB. Next slide, please. So just a reminder that in British Columbia, their First Nations Health Authority is basically the implementer of dental services and health services for First Nations people in BC. So they do not report and submit data to the Non-Insured Health Benefits program. So there is no information, unfortunately, for British Columbia. And as well, for provinces where there were small numbers of claims that could potentially be identifiable, Newfoundland and Labrador, along with Prince Edward Island, no specific data came from those provinces, but we will see that we did get data for all Atlantic provinces under a category of Atlantic Canada. So claims were excluded from provinces and territories with less than 5 claims during the study period. Next slide, please. So the claim period that we were looking at for both this study and then the study that Muhammad Abdullah will speak to in a few minutes really was a 2-year span of time. NIHB implemented SDF claims in August 1st of 2020, and we requested data for a 2-year period of time. I have a feeling that the COVID-19 pandemic prompted them to make this decision to make SDF eligible, so that way children and adults would at least benefit from some form of prevention, secondary prevention or tertiary prevention. So all claims paid by NIHB for dental procedures, this is the data that we received, information on the provider, their province and territory, their specialty, or whether they were a general dentist or a dental hygienist, we received that, along with patient's birth year and the patient's sex. And then we have things as well by the specific province or territory or region of Canada. Next slide, please. So when we look at the results for this first project looking at children under 17 years of age, there were a total of 4,158 claims submitted for 3,465 children. So just do the math there, and we'll talk in a few minutes about potentially not every child benefiting from a second application, which then we will review before we finish the talk today about the importance of follow-up and subsequent SDF applications to ensure arrest. The mean age of the population that we looked at kids was almost 8 years of age, with about 53% of them being female, and the youngest child in the study data that we received was 1 year of age. So here we go as well. Fortunately, though, there were 558 children, even though it's a small proportion, but at least 558 children had more than one claim for SDF. But it stopped basically after 2 applications. So really there, 436 benefited from 2 applications, and that's based on 2 claims being submitted for SDF for those children. Only 109 children had 3 claims, 12 children had 4 claims, and 1 child had 5 claims. So obviously someone was trying to get maybe severe caries arrested in those individuals. Next slide, please. Okay, so not surprising because dentistry, I think for First Nations and Inuit people in Canada is traditionally provided by general dentists. And so not a surprise that the majority of claims were submitted by GP dentists. As well, in the first 12 months of the new policy, there were 1,542 initial claims. So that's actually, I would say, probably a great uptake in the first 12 months of the program. And then in year 2, that second period, beginning August 1st, 2021 to July 2022, there were 1,923 claims. And here, just in the table, it highlights sort of the breakdown. Claims, again, 53% of the claims were for children who were female. The average age, 8 years of age. We've already talked about the number of applications, but our breakdown, pediatric dentists provided or comprised 16.5% of the claims for SDF, the general dentist making up 87%. But let's not discount the role that hygienists also play for these populations, and SDF is part of their toolkit that can be used. If we look here sort of at the breakdown of claims, there were 640 claims in Alberta, 648 in Saskatchewan, 680 in Manitoba and Ontario, 605, and 485 overall claims made for children from Nunavut. And then we do see that as well, most children are also having another claim. They're not just coming in for SDF, but SDF is part of maybe an overall basket of services delivered on a particular day. Next slide, please. So here is basically just a graph to illustrate the number of claims that were made in different quarters. So recognize Q1 is really a summer period. So that was from August, September, ending in October. And then Q2 is November, December, January. And this basically gives us an illustration based on the color coding of provinces and territories, and where we can see. And one of the things that was quite interesting to see is that it did appear that wintertime, during the winter periods, there seemed to be fewer claims, and perhaps this may be related to some transportation issues in people living in remote or rural communities being able to access care during the winter time. Next slide, please. So one of the things that I do want to highlight on this screen here, we did sort of talk about the number of claims made already in certain provinces or territories. But what we did is we also requested data for the overall NIHB eligible population in these particular provinces, but recognize claims are made by dentists working or dental providers working in specific provinces or territories. It is possible that some of the people seeking care, say for instance in Manitoba, may not actually have been residents of Manitoba. So, but this was our best way to try to adjust and report rates by sort of taking the overall number of claims for SDF and dividing it by the NIHB eligible population. And in doing so, we actually see that there are considerably high rates of SDF uptake in Nunavut. 37 children out of every 1,000 were benefiting from SDF. The Northwest Territories as well, very high at almost 21 children per 1,000. And then as well, Alberta, Manitoba, Ontario, and Saskatchewan quite high. And we actually then were able to compare and look at whether or not confidence intervals overlapped to denote whether or not there were significant differences in specific provinces. And of course, Nunavut differed from all regions. There was no overlap. Thanks, Muhammad. Next slide, please. So I'll just share with you that children did have other claims, as mentioned, almost 91% of them. Many of them had assessments. So this could mean that when providers are doing recall exams and hygiene and maintenance, they are identifying caries and deciding that that is a great opportunity to provide SDF for cavitated caries lesions. As well, about 35% of the children had restorative treatment done. So could this be that providers are choosing to restore certain teeth and also then choosing other teeth that are to be managed non-restoratively with SDF? The one thing that we can't distinguish is are people using SDF underneath restorations, which then how would you know if things are arrested or not? I would not necessarily advocate for SDF to be sort of used as a pulpal or a liner underneath a restoration. But then as well, some children were getting forms of sedation, and SDF was part of the mix of services delivered during either sedation or GA. Next slide, Mohammed, thank you. And then here, just looking at, the number of children who were having a second claim, a third claim, a fourth claim. And as mentioned, that seems to be quite low. So it seems to be that most children only benefited from one application. So that maybe triggers a thought that maybe is SDF being used correctly, because it's not like fluoride varnish once and done. And then where the claims were coming from. Mohammed, next slide, please. So just a discussion here. So the ease of an application and its atraumatic nature of SDF really makes this an extra tool for us and helps us to increase access to care for children. It's not that SDF is the only option, or once SDF is done and caries is arrested, that things are left. There are indications where you may still need to restore and rehab a child's dentition. And here we also find that many claims were made by general dentists. However, the fact that many children were only receiving one application really reminds us that we still have to do our advocacy and education to inform clinicians that we should be checking for arrest after SDF applications through follow-up. So Mohammed, next slide. And so we did find very high use in Nunavut and Northwest Territories, probably because of the remoteness and lack of regular access to care, that this product was used to manage caries, particularly during a pandemic. And then Atlantic Canada and Quebec really had low rates of SDF claims. something to sort of think about. Is there something unique in those provinces where maybe SDF might be delivered through other forms of government programming for kids? Next slide, Muhammad. And so I think this is important work, helps us look at the uptake and future trends in SDF use for First Nations and Inuit children. And with that, Muhammad, I'm going to pass the baton on to you to make sure you have sufficient time.
Perfect. Thank you so much, Dr. Schroth, for that wonderful presentation. So we're going to now shift gears and talk about the use of SDF in Canadian adult First Nations and Inuit patients who are covered under the NIHB. So for this study, our goals were to determine the number of SDF claims that were submitted to the NIHB, identify SDF usage trends over time, examine regional and provincial differences in SDF usage, and assess the delivery of SDF alongside other dental procedures, which quite closely parallels the study by Dr. El Azric. This study, similar to the other one, also follows a cross-sectional design. However, the selection criteria is restricted to First Nations and Inuit adults who are over the age of 17 and who received a topical SDF application between August of 2020 and July 2022. So the same study duration. Data for this study, just like the last one, was provided to us by the Department of Indigenous Services Canada via a secure data transfer portal. We received SDF claims data for the 7 Canadian provinces, which exclude British Columbia, Prince Edward Island, and Newfoundland and Labrador, for the reasons that Dr. Schroth mentioned in his talk, as well as we also received the data for the 3 territories. And we also received NIHB population data, which we used to calculate SDF usage rates for 5 Canadian provinces, 3 territories, and the Atlantic Canada region, which was sort of grouped 4 provinces that were grouped together as one. Upon receiving this data, all personal client information was erased, and the data was then stored on a password-protected server at the Children's Hospital Research Institute of Manitoba. And since the NIHB uses procedure codes to reimburse for dental procedures, we looked at the 4 codes that are shown on screen for the data on SDF. Along with the procedure codes, we also received data from the NIHB on the client's age, sex, treatment date, province, and the type of dental provider who delivered the SDF application. And then this data was organized, reviewed, and analyzed using Microsoft Excel to generate frequencies, means, rate calculations, and 95% confidence intervals. So we also took a look at which procedures were provided alongside SDF during the SDF application appointment. And we grouped the treatments that were provided into diagnostic exams and radiographs, preventive procedures, which included things like scaling, prophy and preventive fluoride and sealants, as well as restorative procedures, which is, the bread and butter composite resin and amalgam restorations. We also took a look at some pulpal therapy procedures, prosthodontic procedures, dentures and crowns, caries, trauma and pain control, interim stabilization therapy, and atraumatic restorative treatment, as well as surgeries like extractions and post-surgical care, and anesthesia ranging from general to nitrous oxide and oral sedations. We also used the NIHB population data to calculate the SDF usage rates per 1,000 NIHB eligible people, similar to what was done by Dr. Azric in the study that Dr. Schroth discussed. We calculated the overall rates for each province, territories, and the Atlantic Canada region. And in addition to this, we grouped the clients into 3 age groups, aged 17 to 19, 20 to 64, and over the age of 64 to help further break down the rate calculations. So for this, we divided the number of SDF claims by number of eligible adults, then multiplied this result by 1,000, and we calculated the 95% confidence intervals using the medcalc.org online statistical software. Moving on to the results now, this slide shows us the patient demographics for the clients who received SDF covered under the NIHB. So there were a total of 4,724 SDF claims for 4,370 NIHB clients. 352 clients reported more than a single claim. The mean client age was 39 years old, and over 98% of the claims were submitted by dentists, while it was dental hygienists and pediatric dentists who submitted the remaining number of claims. Looking at the number of claims per year, we can see that 655 claims were submitted in 2020, 2,274 claims in 2021, and 1,441 claims were submitted in 2022. And similar to the other study, considering that this data was reported starting in August of 2020, we sorted the data based on service year to be able to make an accurate comparison between the years. So service year 1, which was from August of 2020 to July 2021, saw 2,014 claims, and service year 2, which was from August of 2021 to July 2022, saw 2,357 claims. And the figure to the right shows the SDF claims data being further subdivided into 8 3-month periods for the provinces and territories, as well as across the country. And we can see the highest quarters where quarter is 8, which was from May 2022 to July 2022. So sort of summer of 2022 for that one. Also quarter 7, which was February of 2022 to May. So sort of the spring of that year. And quarter number 4, which was the summer periods in 2021. This map here shows the number of initial and follow-up SDF claims. The province with the most initial claims was Alberta, with a total of 972 initial claims. And Alberta was also the province with the most claims for SDF reapplications with 169. Manitoba was the province with the second most initial claims, having 965, while it was Ontario that had the second most follow-up SDF claims with 118. And New Brunswick was the province with the least number of initial claims, having only 13. This map here shows the SDF usage rates for each region across the country and is also broken up by the age group. Overall, Nunavut was the territory with the highest rate of SDF usage, with the overall rate being 26 SDF applications per 1,000 NIHB eligible people. This was followed by Alberta with an overall rate of 12.9. And we can also see that in each region, the SDF usage rates were highest in the youngest age group and lowest in the oldest group. For example, we can take a look at Alberta, where the SDF usage rates in the youngest 17 to 19-year-old age group was 13.4 applications per 1,000 people, and in the over 64, it was 10.6 applications per 1,000 people, with the 20 to 64-year-old age group being sort of in between. Now let's take a look at which dental procedures were most frequently delivered with the first SDF application. So the one that was most frequently delivered were intraoral radiographs, which was followed by posterior composite resin restorations, extraoral radiographs, and anterior composite resin restorations. So it's important to note that, many of these were either restorative procedures or diagnostic radiographs, which are commonly provided during the initial SDF application. This table here shows which other dental procedures were provided alongside SDF reapplications, with the most common ones being scaling, followed by intraoral radiographs and preventive fluoride. So this shows sort of a major shift towards more of those preventive dental procedures. Now, over the next few slides, I'm going to expand upon the following key points that sort of highlight our study's results. The first one being the rapid adoption of SDF by dental providers for adults covered under the NIHB. Second being that most Canadian provinces and territories with significant Indigenous populations are adopting SDF. The third one being that SDF is proving to be an effective treatment modality to help address the oral health disparities in Indigenous populations. And the last one is that SDF is being used in conjunction with other treatments. So since its introduction in 2017, SDF has slowly been gaining popularity as a treatment option. And over this study's duration, we saw a fairly significant 17% increase in the materials usage between service years 1 and 2. We can also see that the SDF usage was highest in the summer months. This may be explained by easier transport and access to dental services during these months, especially in remote and rural communities. And across the country, the provinces and territories with significant Indigenous populations, such as Alberta, Manitoba, and Nunavut, had more SDF claims submitted. And we also saw the highest rate of SDF usage was seen in Nunavut. So why are we seeing this? Well, one reason may be that the people who are living in these areas of high SDF usage do experience greater barriers, which greatly limit their access to care, such as transport, which I previously alluded to, and socioeconomic factors. For example, in Nunavut, for many communities, their only opportunity to receive dental care is a visit by a fly-in dentist, which can, range to being up to once a year. Whereas in regions of low SDF usage, dentists may simply have less training on how to use SDF or may just show a preference towards traditional restorative procedures. And this was sort of seen in provinces such as Quebec and the Atlantic Canadian provinces. We also found age to be a key variable in the delivery of SDF. Most SDF research is done in pediatric populations, and this may simply result in less awareness on the use of this material in adult and geriatric populations. And comparing the results of this study with the study by Dr. Azaric that Dr. Schroth was talking about, earlier in the presentation, we saw a 13 times higher SDF usage rate in pediatric populations in Atlantic Canada alone. And among adults, the highest SDF usage rates was seen in the 17 to 19-year-old age groups, whereas the lowest rates were seen in the over 64-year-old age group. And this was seen sort of consistently throughout the country. Another interesting finding was that only 8% of NIHB clients had an SDF recall visit. Now, during the study period, the NIHB did restrict adults to only a single SDF application per year, which has now been increased to 2. And it's important to consider that the SDF reapplications are very important in enhancing this material's caries arresting potential. And this is something that dental providers and policymakers must emphasize to make sure that SDF is being used correctly. So I'm going to pass it on to Dr. Schroth to finish off the presentation.
Thanks very much, Mohammed, and great job again, as usual. You're an excellent speaker. So I think just to end, we just want to remind everybody, I know you're all practicing to the best of your abilities. Just want to remind you again that really SDF is for cavitated caries lesions, and just want you to think about that when you're using or going to be applying SDF in clinical settings. Next slide, Mohammed. So really, if it's primary teeth, whether it's occlusal surfaces, interproximal surfaces, or buccal or lingual surfaces of teeth, if you're trying to think about managing caries lesions non-restoratively and they're cavitated, really 38% SDF based on the American Dental Association's clinical practice guidelines is what is recommended for non-caries management. If they're non-cavitated caries lesions, there's other forms of topical fluorides or sealants that would be best. And maybe a separate talk another day is about that, yes, you can apply sealants to non-cavitated lesions in fissures. Next slide, Mohammed. Again, just as well with the permanent dentition, again, if things are cavitated, these lesions are cavitated, whether it be occlusal, interproximal, or buccal or lingual surfaces. Again, the ADA clinical guideline recommends 38% SDF as the first choice for trying to manage non-restoratively those cavitated lesions to get them to a rest. I think the data for root surface maintenance with SDF is still out there. I think right now what's being recommended is a 5,000 parts per million toothpaste for either non-cavitated or cavitated lesions on root surfaces. And then later SDF is sort of down the list. It shouldn't be right now the default that people go to, and probably most likely because of the significant staining of root surfaces that would occur. Mohammed, next slide. Thank you. So just, this is a very useful guide from the American Academy of Pediatric Dentistry. It's their chairside guide, so you can print this off. You can put this up in your operatories or just sort of bookmark it either on your mobile device or in your operatories on your computers. It just really helps to remind us of, what are appropriate cases, how we should be applying, and what's an appropriate sort of frequency for reapplication and monitoring. And there were some minor modifications made to this document in 2025, and which are now available online. Next slide, Mohammed. So again, who may benefit? Mohammed's really shared this with us, but just to recap, people with high caries risk, people who maybe have behavioral or medical management challenges where traditional restorative care may not be sort of our first option. People who may need multiple restorative treatment visits. So you can use SDF as a way to get some of the lesions that you can't treat right away, get them to a rest. So this way, at least they're not progressing by the time people come back for subsequent restorative visits. As well, maybe teeth that are really difficult to restore. That could be something as well. And then people who face difficulty accessing care. And thanks, Tiago, for sharing that link on Zoom in the chat box. Next slide, Mohammed. So again, just be mindful when, adult or primary teeth, that tooth selection and looking at the criteria is really important. So again, the first one is cavitated caries lesions not encroaching the pulp and have no signs or symptoms of pulpal involvement. So if a parent is mentioning, or if the patient themselves is mentioning that the tooth you want to paint with SDF sometimes acts up, they sometimes get a lingering or unprovoked or spontaneous pain, that's likely not a good choice to apply SDF. And as well, I know for young kids, this may not be possible, but when possible, radiographs might be very helpful to assess the depth of the lesion to make sure that you're not applying SDF on a lesion that's basically sitting right on top of the pulp. As well, cavitated caries lesions on any surface as long as they're accessible with a brush for applying. So AAPD still says brush. I know others have suggested that we can use a superfloss and dip that in and go interproximally. But for AAPD, their chairside guide is still suggesting if you do want to try to arrest interproximal lesions, that look to the use of maybe orthodontic separators to help actually gain separation between teeth. So this way SDF can be applied with a brush. Next slide. So again, age and weight of the child will matter and how much you use for safety. Even though in our studies with young kids, some who were under 2 years of age, we had no safety issues, but there is some just to be mindful. Try to remove gross debris from cavitated lesions. So again, if this is a young child or maybe someone with, a person living with a disability and special needs, Maybe do a toothbrush prophy, get rid of plaque on the teeth before you apply. Do you need to remove caries? It's not necessary to scoop things out, but if you do excavation, it may reduce the proportion of the tooth surface that turns black. But be mindful, but it's not necessary. Prevent sort of any staining or chance of staining of lips and skin by putting on a protective coating. And that could be something like essentially Vaseline on the skin and lips. Next slide, Mohammed. Isolate the teeth using cotton rolls or other isolation methods. You can also maybe put a protective coating on gingival tissues if you're worried about a chemical burn, if you're doing some sort of gum line caries treatments. Simple things about making sure that the brush is bent and making sure that, again, you're using a plastic dampen dish, not glass, because you'll get a little reaction there and don't want to have anything going on in the operatory that could harm people. So again, make sure that if you're applying SDF on primary teeth adjacent to permanent anterior teeth that might have white spot lesions, maybe apply fluoride varnish over top of those permanent teeth, those incipient lesions. So this way the SDF won't stain into those aesthetic areas because those are permanent teeth. And then 1 minute is desired, but there are some studies now coming out. And at the International Association for Dental Research meeting in San Diego in March, there are some that have actually found less contact time can also produce good success. But again, those are on children not presenting with behavior management challenges. And again, remove any excess SDF with either a gauze or cotton pellet, just so that it also doesn't collect on tissues and burn them, but also the child doesn't swallow. Next slide, please, Mohammed. So these are sort of what's really a little bit of an emphasis here is the recommendation for follow-up ranging anywhere from 2 weeks to 4 months now could be done because let's face it, especially if these are children living remotely or rurally, they may not have the ability or adults may not have the ability to come and see you frequently. So it is okay to sort of aim potentially for a 4-month follow-up application and assessment of arrest by checking clinical hardness of the lesion. So again, color change is important, but also take a ball-ended probe and feel the lesion as well to see if it's clinically hard. So usually if you find darkness and hardness, that's a good indicator that that lesion is successfully arrested. And then as well, you can apply a 5% sodium fluoride varnish on top, but even sort of suggesting for these kids, application of 5% sodium fluoride varnish up to 4 times per year is recommended to prevent new caries lesions and to arrest untreated non-cavitated lesions. And then just like everything else, children are children, so we need to make sure that we stay on top of hygiene, dietary practices, so mouth care as well for residents in long-term care, and probably high fluoride concentration for residents in long-term care would be very useful too, just making sort of that crossover for the older population. Mohammed, next slide. And I think with that, we just want to thank you. We'll take some questions now. So a big thank you to Mohammed for partnering, and it was great to also share Dr. El Asrik's work as well. So thanks. Daniela, I'll turn it to you.